All right, here we go. My disclosures. Okay, first case, 82-year-old white female. Recently relocated to your area, is in clinic to establish care. Other than the stressor of her relocation, mild osteoarthritis, and chronic hypertension, her history is unremarkable. Her mother had hypertension, which was well controlled on medicines. And in your office today, her blood pressure is 162/96, the average of 3 readings taken 1 minute apart by the nurse using an Omron device after her leaving the room with the patient seated using the sprint technique. It's the same technique we've used in many clinical trials, including ACCORD, although in ACCORD we didn't tell the examiner to leave the room. We did in sprint. And this woman with that blood pressure is presently on no antihypertensive medications. So she weighs 170, her height 63 inches, her BMI is 31, her waist is 37 inches, her resting pulse is 76 beats a minute. She has no hemorrhages or exudates. You have some arteriolar narrowing, but nothing else. Cardiac exam, peripheral arterial exam, normal, lungs clear, lower extremity, no edema. Her labs, fasting blood sugar 86, total cholesterol 168, LDL 94, trigs 145, HDL 45, creatinine 0.8, GFR 82, cc's a minute, A1C 5.2, ALT 30, TSH normal, the ALT is normal by the way, EKG normal sinus rhythm with definite LVH, voltage and some non-specific STT wave changes, and an intrinsicoid deflection, yes. Okay, medicines, aspirin, baby aspirin, atorvastatin 10, and on no blood pressure medications. First question, which of the following tests would you order in this patient? An echo to confirm LVH, a coronary calcium score, a high sensitivity CRP, a carotid artery intermedial thickness, or no additional tests? What does it mean when the bar goes all the way to the right, Randy, with 100% on the bottom? Oh, is that what it is?
Yeah, you're accumulating.
Wow, the first person. Okay.
It would be better
Yeah.
on there, but
Okay. Ah, look at that. Yeah, yeah.
that would be good.
Oh gosh, I don't think that many people are voting. Okay, who wants to get an echocardiogram? Yes, why?
Data.
What?
The data is helpful.
The data?
Data from the echocardiogram.
Oh, what? Tell me what? Tell me what, because I've always put a sign on my wall for the medical students. Our technological advances have superseded our knowledge of knowing when to use them. Don't do a test unless it will change what you do.
It would change my difference.
Okay. I think the best answer is no additional tests. I don't think you need an echo once you have LVH by EKG. We don't recommend an echo as a screening test in hypertension. It is true if you don't see LVH on EKG, you still may see it on echo, but echoes are very expensive. We can't do limited echoes. Cardiologists want to tell us about a whiff of this and a whiff of that. And since you know that there's LVH on that EKG, you're home to the races. By the way, LVH just tells you the burden of disease. It does not specify a particular drug that is best. We have had regression of LVH with good blood pressure control, and that blood pressure control has occurred with thiazide diuretics, calcium blockers, RAS blockers, and beta blockers. So LVH regression should not be a recommendation for a specific drug. Yes, question?
So in a patient like this, they're eventually likely to get heart failure. You yourself said yesterday that it's helpful to know if there's someone what the pattern and the history was of their ejection fraction.
A patient like this is not likely to get heart failure if we had taken good care of her blood pressure, and I agree, but if she develops signs and symptoms of heart failure, then I would get it. I don't think insurance companies would pay for an echo right here. And honestly, you'd have to create something that's not there. Maybe you'd put shortness of breath or whatever you'd put on that chart. But for this particular presentation, if I was an insurance company, I don't think I'd pay for that echo. I know it's different than what you might have wanted to hear. Coronary calcium score, the patient's already on a atorvastatin. Now, once again, you can get a coronary calcium score for the burden of disease, but I don't think it's going to change what you do for the patient. You know, you can go into the Jacksonville Mall in Jacksonville, Florida. Anyone from that area? And you can get a total body CAT scan. The problem is you're going to find incidentalomas that are going to then put you down that slippery slope of somebody wanting to do something about it, because the radiologist is going to tell you everything they see. And when you have a 3 millimeter of this and a 4 millimeter of that, or something in the liver that's of no significance, it really probably should have never been done in the first place. I don't think high sensitivity CRP is going to help you, and we don't recommend carotid intermedial thickness. I know there are vans going around the country, all around the country, doing screening tests for patients for $100, and one of the things is a CIMT. Forget about it. The technology is not good, it's not standardized, and the most recent ACC/AHA guideline did not recommend it. So my best answer here is no additional tests. Which of the okay, so 5, no additional tests. Now, I showed you this yesterday. If your coronary calcium score is 0 over 5 years in patients without any cardiovascular disease on entry, in the ARIC study, the atherosclerotic risk and cardiovascular outcomes trial, you are at no risk of developing coronary events. It is true, the higher your coronary calcium score, your greater your risk, and you're not quite sure what to do when it is not 0. But if it is 0 and you're on the fence of a statin, you're not going to add a statin. Any other value, you're going to have an informed decision with the patient based on what you think is best. In addition to lifestyle modification with our patient who's 82, how would you treat her blood pressure? So answer now. A thiazide-like diuretic, an ACE or an ARB, a CCB, either 1, 2, or 3, or a combination pill from the get-go, an ACE diuretic or an ACE CCB. So what's the best answer here? And I've got to go to this so you can answer. Sorry. Yeah, this is good, like a good democracy. We've got a variety of good answers. Okay. Any of the 4, well, I'll tell you, I think the best answer here is either 4 or 5. And that's here. And I say that normally I'm a huge advocate of initiating combination therapy when the burden of blood pressure reduction is 20 over 10. So if your goal in this patient was less than 140, she starts at 162, you could start with a combination pill. Favorably priced, well tolerated, a little bit of both medicine gets you more blood pressure reduction than high dose of one medicine. But in an elderly individual, 82, in these people, I think starting with one drug at a lower dose is fine, as long as you know she's coming back and you have time, et cetera. Yes?
I'm still old school. I like to know if the patient has a side effect, which one's good. I mean,
Okay.
Angioedema, and you've got them on a combination, yeah, it's the AC.
I hear what you're saying. You're old school. I'm old school. A lot of us are old school. We like to hold the journal. We don't like to just read it online. I understand. I know how you feel about that, but I'll tell you, I can always predict the side effect even if they're on a combination. But I understand.
You can't predict if it's an allergic reaction.
An allergic reaction? Yeah, angioedema is the RAS blocker.
Yeah, I'm talking about hives.
Cough.
Cough, yeah, cough and angioedema, no problem.
Yeah.
But, you know, if it's hives or something, no.
Yeah. Boy, I'll tell you, I can't tell you how many people I've treated, and hives occur sporadically, but from one of these medicines, pretty unlikely. even sulfur-based medicines. Yes?
Initially, I always thought that maximizing the ACE would be of greater benefit as far as long-term benefit, renal preservation, plaque stabilization, and then add the diuretic if you need it.
Oh, you have? Yeah, that's not true. I'm going to show you the data on that. It is better to add 2 drugs of different pathophysiologic mechanisms for blood pressure reduction, especially in a patient with normal renal function, in which there's no particular indication for an ACE or an ARB. Now, she is Caucasian, so we say you can add 1 of 4 drugs, an ACE, an ARB, a thiazide-like diuretic, or a CCB, and the choice is yours. If this patient would have been African American, the diuretic or the CCB would have been preferred because they have normal renal function.
So you would add a combination right from the beginning?
You could, but she's 83. So I would give full credit to students that answered number 5. I'd give full credit to students that answered 1, 2, or 3. I think you can do both. If this was a 48-year-old individual, especially if I was concerned they may not get back to me, I would probably start with a combination. And we've written about this. We have a position paper in the American Society of Hypertension, and I was the author on it. And we talked about ideal combinations. And we felt as initial therapy, which are FDA approved, it's an ACE diuretic, ARB diuretic, ACCB, ARB CCB. Lotrel, for instance, is $4 in BiLos in South Carolina. Amlodipine, by the way, is a free drug in BiLos at South Carolina. Publix in Florida, South Carolina, Georgia are giving away free metformin, lisinopril HCT, that's right, they are free to your patients, and 5 antibiotics just to come into the store. So patients who have no money can get these medicines through their grocery store. Y'all familiar with that? Yeah, it's true. It's true. Yeah. And I'll tell you, if you practice in a small town, you can meet with these supermarkets and you can try to convince them to give some patients that really are poor some of these medicines for free as a public service, promoting it in the community, et cetera. Publix is doing it across their chain. BiLo is doing it, so it can occur. Okay, so the first 3 medicines in patients with hypertension we prefer to be a diuretic, thiazide-like diuretic, an ACE inhibitor or an ARB, not both, and a calcium antagonist. Now, you can use diltiazem or verapamil, but I'll tell you, we tend to underdose these drugs. Verapamil at a good blood pressure lowering dose is going to cause constipation in any and every 83-year-old. It's almost universal. It'll bind up your bowel. The calcium blockade decreases the contraction of the bowel. It's very, very disconcerting. Diltiazem is a great drug, but clinicians tend to underdose it. I see people coming into my office on 180 or 240 of Dilt CD, and it's well priced, but that's like calling the fire department and only giving them a hose, a straw to put out a fire. Dilt at 360, 480, and 540 is a good drug for blood pressure, but not at the doses that clinicians use. So I prefer amlodipine. I like 10 more than 5 than 2.5, but if mama gets the Imelda Marcos swelling of her 83 pairs of shoes and she wants open-toed shoes, you're going to have to use 2.5. But any amlodipine or nifedipine is better than none. And 2.5 of amlo is 30 of long-acting nifedipine, 5 is 60, 10 is 90 or 120. So the nephrologists like the nifedipine long-acting because they have 90 and 120 that they can give to people. I'm an amlodipine guy. And affordable, well tolerated. If you were going to Haiti, any of you do missionary work? Okay, if you're going to if you will, a third world country, a poor country, and you want to control blood pressure, amlodipine's your drug. It doesn't require any blood pressure monitoring, does nothing to the metabolic profile. K stays the same, glucose stays the same, and it's well tolerated. You could put 2.5 of amlodipine in the water of Haiti and do tremendous good for those people. So that's your drug. Because a diuretic, you've got to watch K. You've got to watch renal function. Or a RAS blocker, you've got to watch K. You've got to watch renal function. So it's not as easy to put in the water of those countries. But these three drugs are just fantastic as initial therapy. And we like these two in blacks. And we like beta blockers. And cardiologists love beta blockers, but only when they're post-MI, have AFib with superimposed hypertension, and only post-MI for the first 2 years where the evidence is greatest for benefit, and in heart failure with reduced EF. Questions?
How about your migraineurs?
A migrainer, so yes, you want to use a beta blocker there, the twofer. Yes, or an alpha blocker when there's BPH and hypertension. But we don't want you to use alpha blockers unopposed. In the ALL-HAT trial, those on Cardura as initial therapy had more heart failure and had more reason to, that arm of the trial was stopped early because they had more cardiovascular events. We got faxes in ALL-HAT when we compared chlorthalidone to lisinopril, chlorthalidone to amlodipine, and chlorthalidone to Cardura, doxazosin, in 42,000 hypertensives. And we were told in the middle of the trial the doxazosin arm was being stopped because that group had more cardiovascular events. Now, what may have happened? At the time of randomization, these folks that may have been on a diuretic were not allowed to be on a diuretic. And so they may have had a proclivity for heart failure, like you were hinting at, and now that we don't allow them a diuretic and we only give them an alpha blocker, they go on to develop heart failure. So a lot of complication there, but we do not use alpha blockers unopposed in hypertension without a RAS blocker or a diuretic. Okay? Good. As a twofer. Any other questions so far? Yes?
Could you speak briefly about the difference between metoprolol, succinate, and tartrate?
Yes. Yes. Some of us that are a little follicularly challenged, gray in the hair, we remember low pressor. That was the tartrate. It's a BID drug. It has a half-life of about 12 hours. Excellent medicine. Generic, $4. The succinate is Toprol XL, long-acting, and in hypertension it makes no difference. You can use either, it's just convenience, but in heart failure it does. Because when carvedilol was head-to-head BID compared to metoprolol tartrate BID, carvedilol won. It's a superior drug, same beta blocker class, superior outcomes in heart failure. So I'd rather see you use carvedilol for heart failure with reduced EF than the tartrate BID, but toprol in the MERIT heart failure trial had excellent outcomes, including a 34% reduction in death. So the long-acting once a day for heart failure with reduced EF, either one in hypertension. And I like metoprolol, I like nadolol, I like any Adderall or whatever better than I like atenolol because it's a BID drug. You want to use tenoritic, take the 125 with chlorthalidone and split it and use it BID. Because of the atenolol. Chlorthalidone has a half-life much longer than 24 hours. Yes?
The nephrologists in our community have been stopping Norvasc.
Why have nephrologists been stopping Norvasc?
I have no idea. They just said it was bad for the kid. That's what they told the patient.
Okay. We do not stop any medication in hypertension in patients that are uncontrolled unless they're dangerous. So we use additive strategies, not substitution deletion. Amlodipine, when used with a RAS blocker, is never deleterious to the kidney. Where do you live? Where?
Texas.
Texas. Yeah, that is the devil's work. That is the devil's work.
I've been seeing some follow-up, and they've been telling patients that, and I was like, I said, I haven't read that.
So here's what's going on. Amlodipine has a preferential ability to dilate the afferent arteriole of the kidney. That is the blood coming into the glomerulus. You have all these glomerular units, a million glomerular units. They have an afferent arteriole, they have an efferent arteriole. In hypertension and certain diseases, the RAS system is activated, where efferent arteriolar constriction occurs. So someone's kinking the hose on you, so the pressure in the glomerulus is increased. When you give a RAS blocker, you unload that pressure behind the glomerulus, and the glomerulus now can get a nicer pressure. and it can filter better and get more renal blood flow. When you use an amlodipine or nifedipine by itself, you dilate the afferent arteriole. You increase renal blood flow and create hyperfiltration. And eventually that can harm the kidney. So you want balance. That's why you always are good in any patient with amlodipine or nifedipine on top of a RAS blocker. Oh, I love amlodipine. What?
I said I did too until they told them that, so now I've been.
Oh, don't stop amlodipine. Just make sure they're on a RAS blocker and amlodipine. And protein is even reduced because they both together lower blood pressure more. You can't out-trump blood pressure. What would you rather have? A patient with a blood pressure that's elevated on a RAS blocker or a patient that's well controlled on a thiazide diuretic? Of course. But you know, we have been fed this Kool-Aid thinking that RAS blockers are the chicken soup of life. They're not. They're right in the right patient population. You know, it's all about blood pressure reduction. And most of the blood pressure reduction with diuretics is on peripheral vascular resistance, the unloading of that, especially in the elderly, not on the urination. Yes?
Are you saying not to use amlodipine by itself?
No, you can use amlodipine by itself in a low-risk patient, absolutely, with no kidney disease, absolutely. But these are nephrologists, and they're seeing the worst of the worst, so they're all on a RAS blocker. Why would they stop amlodipine?
Because they like the Cowboys in Texas.
Because they like the Cowboys.
I'm with you. I mean, the nephrologist in our hospital, I might have somebody on amlodipine and they come along and next thing I know they're on nifedipine.
That's just a preference. You know, that's a preference. They like Showtime more than HBO.
I don't understand that.
What?
I don't understand that.
Let me just say this. Anytime anybody does anything to your patient or says something like me, don't you have the right professionally to say, Dr. Basil, where is the evidence for that statement? Why are you saying that? If I said something to you that you didn't agree with, you should ask me in a nice way, and I hope I'm being nice and not, disparaging when I say I wouldn't get that test. I mean, it's my opinion, but I better have a good reason. And if I don't, let me tell you, it's just my opinion. My opinion's not better than yours unless I have evidence for why I'm saying what I'm saying. And I think if someone stops a medicine and changes it to another, this is your patient, they should be able to have a good explanation for you. Just like in medical school, my professors used to tell me when I would ask them, why are you recommending it? And they would say, because I have 40 years of experience, just do it. Today you can't do that. And it's not appropriate. It's because in studies, we've learned that this is better than that. And if we don't have that, which we don't, fine. Then in my experience, because this is an area of unresolved controversy, we go in that direction. Yes, questions?
Your thoughts on bistolic?
Yes, I like bistolic. When it's generic, it's going to be a preferred beta blocker because it's so well tolerated. I see a lot of spouses of physicians who do not like their beta blocker. I also see physicians with hypertension uncontrolled on a beta blocker. Let me tell you, just go into the sample closet and take a beta blocker BID. You will be dragging at 4 o'clock. We are hardworking people. We have a lot of energy. These drugs reduce heart rate and they reduce cardiac output. Yes, that's what we want them to do. And they can make you feel sluggish. And so patients don't like to take traditional beta blockers. Some. Nebivolol is a preferred, well-tolerated beta blocker. So I like it. I wouldn't use it in heart failure because I got too much evidence with Coreg, Carvedilol, and Toprol XL. But in hypertension, if the price is right, perhaps. Absolutely. Yes?
Along that line with other beta-selective blockers, is it, labetalol and
Bisoprolol is a non-vasodilating beta blocker. Labetalol is a vasodilating. It's what I call a beta alpha blocker. It's more beta than alpha, but it has alpha. Carvedilol has a little more alpha with beta. I prefer Carvedilol to labetalol. Yeah. Labetalol is good parenterally for a hypertensive emergency, which are very few and far between. Yes?
Why, with bistolic, why do you think
because the FDA would not move on the seniors trial, which is a European trial with no Americans, no North Americans. They just weren't going to approve a drug based on non-North American population. Yeah. Okay. So the HIVET trial. So this is a trial you can refer to. At the time, it was controversial if the oldest of the old should be treated for hypertension. And in this particular trial, done in Europe, 80 years of age and older with blood pressures, a goal of whom which was less than 150 over less than 80, large numbers of patients, average age 84, systolic hypertension, either isolated systolic or combined systolic hypertension, combined systolic diastolic. Started with an ACE inhibitor, perindoprel, and then they could add the diuretic indapamide, and that's why we use the term thiazide-like or thiazide type, because it is not a pure thiazide, but it is of the thiazide class. It's thiazide-like. And this trial was stopped early because the Data Monitoring Safety Board saw that in the placebo group, they were dying sooner. And those on the ACE inhibitor with or without the diuretic indapamide were living longer. The difference in blood pressure was 15 millimeters of mercury. And so they were 84 years of age. Here were their systolic, stage 2. 1/3 had isolated systolic with diastolics less than 90. They were a fairly thin and robust sort of group. Only about 11-12% had underlying cardiovascular disease. Not that many had diabetes. Here were their lipids, good renal function, double-blindly randomized to one of two therapies, placebo versus active therapy with perindoprel and indapamide. Blood pressure significantly reduced. Trial stopped early because if you weren't on active drug, you were dying sooner. So it was felt unethical not to treat patients, mean age 84, and now we think there is no age at which hypertensive patients with this degree of hypertension for sure should not be treated. Age alone is not a reason. Look at all these outcomes. This is a forest plot to the left. Active drug was better than placebo. I mean, gosh, everything's going in the right direction. Yes?
In the elderly, sometimes you have a big gap between the systolic and diastolic blood pressure. And
Yes.
like you may have a 180 over 70 or something like that sometimes. So it's systolic hypertension, and we know that increases their risk of stroke, I guess. But and I guess maybe cardiovascular disease in general. But in treating those, any pearls about, because you don't really want to lower their diastolic that much, and so you may not want to give them a diuretic, but can you?
Yeah, great question. Okay, so if you're untreated and you're being followed by your physician, clinician, and your blood pressure is 180 over 100, and your neighbor or your twin brother is 180 over 70, which would you rather be? How many want to be 180 over 100? All other risk factors the same? Only one? How many want to be 180 over 70? Wrong answer. The wider the pulse pressure at the same systolic, the greater your risk for death. Heart failure, heart attack, kidney disease. The narrower your pulse pressure, even at the same systolic, the better your prognosis. And that gets to our treatment. We want to keep the diastolic pressure in all patients with hypertension no less than 65, and if they have coronary disease, no less than 60. So if you are starting at 180 over 70, that's a high systolic burden, you don't have much room to lower diastolic, because coronary flow and coronary ischemia is dependent on diastolic pressure and diastolic flow. So you'd rather be 180 over 100. And we want to get the systolic to less than 140, if not lower. So it's a balancing act. No particular drug. Lower the systolic, watch the diastolic. Lower the systolic, watch the diastolic. And there will be a point when you'll tell the patient, well, with that class of drug, I feel I can't lower your systolic anymore. And if you exhaust all the classes of drugs, you may be left with a particular pressure documented in the chart that you could not lower systolic anymore based on the diastolic blood pressure. And that happens in clinical practice all the time. Yeah, it's unfortunate. So yeah, the pulse pressure is a big prognostic factor. And the wider the pulse pressure, the worse the prognosis. What it's basically telling you is that in diastole, these vessels do not have the ability to generate a good enough pressure to sustain diastolic flow.
In the elderly, I'm always concerned about dehydration, not drinking enough water, so I'm always a little concerned about using a diuretic, especially chlorothalidone, because in the elderly. I mean, is there appropriate concerns for that? Am I overly?
There are appropriate concerns, but in all the studies we've done, chlorothalidone in the oldest of the old, awesome drug. In the SHEP trial, less stroke, less heart attack, less heart failure. So go with 12.5, and if you have to, and it's hard to do because it's not a scored tablet and it comes in 25, go with 6.25. Very long acting, great outcomes. Yes?
So can you put a little asterisk on the pulse pressure thing where the very old or people with medial sclerosis, you don't want to go too low because they won't be able to keep the pump going.
Well, let me show you that data, but I hear what you're saying. You're very concerned about how low you go. Clearly that is true with diastolic blood pressure, but you're right, it could be true with systolic. And if your patient's getting cognitive concerns or lightheaded or gait abnormality, weakness, yes, you have to do what's best for the patient. So that's why it's always an art of controlling blood pressure and not a fixed, regimen. And what's good for one patient is not good for the other, and that's the individualization. That's why it takes someone like you to be the practitioner. You make the decisions based on the response, and not all of them will respond the same. That's true. Very true. Yes?
Right. Given the concerns about the pulse pressure, what is the most accurate diastolic pressure? I've heard that where the sound changes may be more accurate diastolic because those electronic digital things can pick up a diastolic.
The electronic machines are predicting the diastolic based on an algorithm of the systolic. The dissipation of all Korotkov sounds is the diastolic. If you hear a fourth and then a muffling and then a gone on the fifth, you say 160 over 70 over 62. And that's to tell the next clinician that you realize there is a change in the Korotkov sounds, and then there's an absence of the Korotkov sound.
Bottom is a true diastolic
Is the absence.
Do you think the digital picks up a lower diastolic than manual sphygmomanometer?
I think the digital can be used for systolic and diastolic. Yeah. Okay, so we're going to move on. So what would you do next? So let's see, our patient is on, let's say our patient's on 12.5 of hydrochlorothiazide. I forget, what was our patient on? Did I tell you? What's that? We didn't decide yet. Okay, so just tell me what you're going to do. You're going to put the patient on an actual drug. Tell me what you'd like to do. The pressure's 162, she's 82, good renal function, has been on therapy in the past, stopped her medicines, comes to you, you're the new clinician in the area, and you need to make a decision on treatment. So 71% want to, 56, 60% want to start with a low-dose combination. Others want to go to amlodipine 5. That's it? Oh, interesting. Okay, there we go. 7% want to start an ACCB. Nobody wants to do nothing. Okay, I think either switch to lisinopril 20, HCT 12.5, or 25 of amlo, probably the best answers. Actually, the patient was started on HCTZ because she was elderly. I think combination would have been just as fine. The patient returns in 1 month later and has gone from 162 to 150 and 96 to 90. And what would you do next? This is when I think you would, instead of up-titrating the diuretic to the ceiling dose, you actually get more bang for your buck by going to a fixed-dose combination or 2 separate pills if that's what you want to do. When you look at a study of 60,000 individuals in a meta-analysis of 341 trials, and you look at the blood pressure response from the half dose, be it 5 or 12.5, half dose of these medicines, to the full dose, you'll see that you don't get much more blood pressure reduction. In fact, let me just tell you that about 60 to 80% of the blood pressure reduction that occurs with the initial dose of every class of antihypertensive occurs with the first dose. So you'll always get more bang for your buck by adding a drug from another class that works very well with that first drug. Yes?
Quick question. Why would you go to the lisinopril 20 instead of lisinopril 10 with the hydrochlorothiazide in that previous case?
Because I like 20 more than 10. I just, I got to tell you, if you're treating me, I like 40 more than 20. But then you're getting into the pleiotropic effects, and is there something special outside of blood pressure reduction? And I really think it's more blood pressure reduction. So I think 20, 12.5. I'm comfortable with 20. The ACEs and the ARBs do not have dose-limiting side effects. They have, all their side effects are not related to dose. Cough's not related to dose. Angioedema is not related to dose. So I don't have any problem with 20 versus 10. Now, with a diuretic and a CCB, the side effects are related to dose. So there, I like to start with the lower dose.
Well, I'm just thinking with the synergistic effect of the hydrochlorothiazide and the ACE, I worry a little bit in the elderly about dropping it a little too much. So I use.
She's at 160. She's at 160 something. She's got LVH. Then you do 10. No problem. I don't have any problem with that. No, I'm serious. I don't have any problem with 10. Here's my concern, because I see it. These people get lost to follow-up. Yeah. And as long as you're following the patient and they're coming back, I don't have any problem with 10. I just like 20.
Well, and
there's no right answer.
Not a problem this month. It's
yeah,
so
yeah.
follow-up.
And she's got long-term problems. She can develop heart failure with preserved EF. So you're right, she's got long-standing LVH with hypertension. So this just shows you the symptom reported subtracted from placebo. And of course, if you stay with half dose, it's not really much more. But if you go to full dose, you're going to have more side effects. So I like, lisinopril, diuretic, and half the dose of both. But then let me tell you, a lot of times, if the blood pressure is controlled, depending on what's going on, I might go to 40, 12.5 instead of 20, 12.5. But 20, 12.5 is a great dose. So I think that's great. Okay, so what goal blood pressure would you try to achieve in this 82-year-old? Less than 120/80, less than 130/90, less than 140/90, less than 150/90, or have the patient involved in an informed decision. Ted, I got started a little late, so we're about 15 minutes behind. Okay, it's interesting. So I think let me just leave you with the understanding that the minimum threshold in hypertension control, regardless of age, ethnicity, underlying disease, is less than 140 over less than 90. There is no less than 150 over less than 90. The evidence is less than 140 over less than 90. And if you're looking for a sweet spot for all of us, it's probably 130 to 139 over 80 to 89. The problem is when we give a systemic antihypertensive, the brain, the heart, and the kidneys, which all sees the same blood pressure reduction, likes different blood pressures. The brain is very forgiving. It likes a lower pressure to reduce stroke. The heart, not so. The heart does best at a systolic 130 to 139, and a diastolic, as I told you, if there's coronary disease, certainly above 60 to 65. And you don't want to lower it more. And the kidney, it needs pressure to sustain renal plasma flow. So you don't want to lower it too low. And these are some of the issues that we're dealing with right now. But I will say that this answer here, I don't think is a good answer. Now, there will be the oldest of the old where that's the best you can do. Because as you try to lower them more, they'll have side effects, or they'll get orthostatic, or something will happen. Cognition will change. So these are all important issues. But we do have the SPRINT trial, 130 to 180. About a quarter of the patients were 75 years of age and older. And we reduced the pressure from a mean of 139 to the standard group, which was 136, and the intensive group goal was less than 120. We got down to 121 by 1 year, and we sustained it for the whole trial. It only took one more class of medication, 3 classes versus 2, to do that, to get to lower. Okay, but is lower better? Well, when you look at the outcomes, lower is better. And I haven't shown you this data before, but this is published after the whole sprint trial was published in the New England Journal. This is the oldest of the old subset, just those 75 years of age and older. And notice, for the primary outcome and for all-cause death, targeting a goal of less than 120 was associated with less death in patients over 75 years of age and older. Interesting. And when you look at frailty index, and you look at, in red, intensive, this pointer doesn't work, versus blue, even in those that were frail, by the frailty index that geriatricians use, lower was still better. So I don't want you all to be driving blood pressure that low necessarily, but I want you to know in the sprint elderly cohort, the lower blood pressure was better. Now here's the kicker. We have not published the cognitive functional analysis of what happens to patients as we lower pressure to 121. The mean, by the way, in the elderly here was 123. So it is possible that although they will live longer, their cognitive ability is worse. Stay tuned. So I don't think you have to get to this lower pressure yet, but we're going to have guidelines coming out this summer. And they're going to be published, and they're going to address all these points. The main point here is lower is better. How low is unclear. Clearly, we'd like everyone less than 140 and less than 90. Questions?
Was there a study where under 140, I mean, to a certain point in time, your condition worsened, if you got the blood pressure too low?
Well, this is a mean 3.26-year follow-up in patients 50 years of age and older. There were patients over 100 in this 75-year and age older group, and lower was better. They lived longer. They had less cardiovascular events. Yes. Now, they have more hypotension, 1 per 100. You've got to make sure they're not orthostatic. First, do no harm. But my main point here is just to let you know, you're not wrong for trying to get them to a lower pressure, but I wouldn't criticize you if you have difficulty doing it and you can't. Just document it in the chart. But don't let them hang out at a high pressure because that's the pressure they need for cerebral perfusion. If that's what you think, you have to have good reasons for it. The patient becomes confused when I try to lower her pressure anymore. Okay, that'll work. And so 146 over 94 is the best pressure for this patient. That's reflective, that's thoughtful, and it explains why you are doing what you're doing. Yes?
Yes, does the Joint Commission take into account for these other articles that come out that reference the elderly and the max systolic or lower systolic number?
The bottom line from all of us is individualization. And if your chart is reflective of thoughtful understanding in your patient, they can't ding you. They can't ding you for that. Yeah. So watch the electrolytes, the sodium and the potassium. Check them for orthostasis. What goal would you try to achieve? I think the best answer is less than 130 over less than 90, because we don't really have a trial that specifically looks at the diastolic. But overall, like I said, less than 140 over less than 90 is just fine right now. Understand in the future it may be a little lower. It comes from this particular trial. There's no harm in doing it. It looks as if the elderly can tolerate it. And remember, these are elderly patients that were non-hospitalized, and when they came into the clinic, they walked into the clinic. They had to be ambulatory elderly patients. Couldn't be in a wheelchair, couldn't be from a nursing home, okay? So these are just people that are older and they're being treated for hypertension. Okay, so I'm going to move on. There's the less than 130. Given the results of SPRINT, as she is older than 75, her lower blood pressure goal of at least less than 130 over 90 was agreed upon. She was up-titrated over 6 months when seen to lisinopril 40/25. The blood pressure decreased over the next few months. Added amlodipine, got to 126 over 88. She's feeling well. Her BUN, potassium, creatinine, not orthostatic. Everything's going well. Individualization, thoughtful approach, understand the literature, do what's best for that individual patient in front of you. One size does not fit all. Very important. This is not cookbook medicine. This is individualized care, understanding the evidence, but yet treating the individual patient. Okay, going to move on to another quickly, yes?
Just, I know it's not really JNC8, but whatever was.
Well, JNC8, we're moving on from JNC8. The goals were too high in JNC8. Forget about it. Less than 150 over less than 90 was the evidence at the time. We got new evidence. Okay. Yes?
An elderly coronary calcification has any effects on resistance to medication?
In the elderly with coronary calcification, clinically, if you get resistance, then you see that there's arteriolosclerosis as opposed to just atherosclerosis. So there can be. But we don't use coronary calcium to determine that. We treat patients, try to lower their pressure. If there's resistance, there may be a problem. And that may be where central blood pressure will be used in the future, in the oldest of the old, where it's hard to get a good reading peripherally. Yes?
If they're diabetic, years ago you said 130 over 80.
We don't say that.
So that changed.
2017, 3 days ago, the ADA came out with their new standards, published in January, this coming, in diabetes care. Less than 140 over less than 90. Diabetes. 130 to 139 over 80 to 89 is such a good place to be. Yes?
How soon do you bring your patients back for titration? 2
Excuse
weeks,
me.
4 weeks?
Excellent question. As often as you would like and your panel will enable you or allow you to do. I'm serious. I think that we can use labs with our nurses very effectively, and someone needs to be helping us check this for us. But in SPRINT, we saw them back every month for the first 3 months and every 3 months thereafter. So if any bean counter, any insurance company, any EMR group is going to hold you to the SPRINT data, they've got to enable you to have a panel size where you can do this, because you can't be cavalier here. You can't be seeing these people back every 6 months. If they're going to force you to see people every 6 months, and you can work this out. You know the number of people. I mean, if you have paper charts, it's a tough problem. I asked some people, how many people do you follow? I follow 12,000 people. Well, how many are active? Well, at the VA, we know exactly how many are in their panel. And currently, we're holding it to about 1,250 nationally. Now, if we find that this is going to be exported to all of them, well, we're going to have to create slots for them, and maybe they can't follow 1,250. So that's a real issue. Don't be seeing these people back every 3 and 6 months who are 83, who you're going to try to lower their pressure to less than 130. You've got to do what we did in the trial. And they have to have access to you by phone call, as they did in the trial. Yeah, very important. Okay, case 2, and then we're going to stop. Case of severe hypercholesterolemia. It's a 35-year-old white male presents to the lipid clinic after having an MI and a PCI 3 months ago. History of elevated cholesterol with bumps on both ankles from about the age of 20. Family history of maternal severe hypercholesterolemia and premature coronary disease. He has been on statins off and on since the late 20s, presently taking Atorva 80 for the past 3 months, tolerating it well, has 2 younger siblings who he has had no contact with. He's on Atorva 80, Prasugrel 10 for the stent, metoprolol 25, and metformin 500. 128/68, BMI 26, normal cardiac and vascular exam. But these are what you feel on the back of his heels. So what are these? Xanthomata, Achilles xanthomata from familial hypercholesterolemia at age 35. So this patient has, just thinking about it, familial heterozygote hypercholesterolemia, strong family history, might have been dead at age 20 or 25 if it was homozygous, but this is what's going on. If you go back in the chart, which is very instructive, you'll find originally the LDL was 256, the sugar's fine, the trigs HDL not bad, normal renal function, A1C good, ALT normal, TSH normal, EKG normal. Now on 80, LDL is reduced about 50-something% to 143, and you see the other lab parameters. So, familial hypercholesterolemia, it's an autosomal dominant disorder. Predominantly, it's an LDL receptor defect. Not enough LDL receptors. There's a loss of function of the LDL receptor or a loss of production. But it can also involve the ApoB or the PCSK9, where there's a gain of function of PCSK9, which scavenges the LDL and chops it all up, degrades it, and you can't bring your cholesterol back in. LDL goes up in the blood. So these folks are heralded by severe hypercholesterolemia, and it depends on the age they present. Our patient is illustrative of heterozygote hypercholesterolemia, and it's under-recognized. High-potency statin is often not enough. So this just separates the homozygous, the double whammy, which is much rarer than the heterozygote who are out there. And really, if the LDL is, like I said yesterday, greater than or equal to 190, you got to think about it. And you saw our patient was 300 and something, now on the high-potency statin is 146, has already had a stent and a family history in the mother, and so chances are this is heterozygote hypercholesterolemia. And these are the Simon-Broom criteria. These are Dutch criteria that allow us to make this diagnosis. In this country, insurance companies will not pay for genetic analysis. In our patient with tendinous xanthomata, an LDL of 327, a personal history of disease, and a family history of disease, you've got your diagnosis. So the question is, and this just shows you it's like a Chinese menu, in order to make the diagnosis of heterozygote definite or probable, you need A and B or C. And for probable, you need A and D or A and E. And as you go through that, our patient qualifies. So this is a very important slide because it shows you the natural history of what happens to people that have a huge burden of LDL because they have no LDL receptors and they're homozygote hypercholesterolemia. Their burden of LDL is translated into ravaging atherosclerotic disease at a younger age. If they only have the single defect, they don't have as quite a burden in the height of the LDL over as many years. You can see the normals, and you can see what drugs and statins can do in green. And the idea here is you try to minimize the risk factors, can't do anything about gender, but control blood pressure, get the A1C controlled, they're not smoking, they're exercising, their weight is now more ideal, so you're splaying them off to the right while you're now going to get their burden of LDL excess lessened so they can live longer. And that's the whole purpose of this conceptual model of why we do what we do for all of our patients at risk for atherosclerotic or with personal atherosclerotic disease. Come on. Okay, so what would you do next in this patient? On Atorva 80, LDL 146. Add a bile acid resin, add ezetimibe, add niacin, add phenylfibrate, add a PCSK9 inhibitor. Okay. These are the right answers. And the insurance company may or may not want you to add ezetimibe yet. Remember, these people with ezetimibe in the simvastatin, ezetimibe versus simvastatin alone trial had acute coronary syndrome. So they were PCI-type patients. So you could add ezetimibe. And maybe, and hopefully in this patient, they're going to approve a PCSK9 inhibitor. Okay. So that was the right answer. Perhaps ezetimibe is the best answer here. It is the first choice. It's a little bit more cost effective even with current prices than the PCSK9. Bile acid sequestrants could be considered. PCSK9 inhibitors may be considered if the goals of therapy have not been achieved on the maximally tolerated statin and ezetimibe. And that's what the insurance companies, the payers, are going to tell you. This is the Improve It study. It falls right in line for the minimal LDL reduction, but it did reduce coronary events. These are the drugs that are out there now. Let's just cross off bozizumab because in the clinical trials over time, it lost its efficacy. Why? Because it had a Z. And because it has a Z, which these do not, it is humanized. And because it's not purely human, we develop antibodies to it, and over time, the LDL comes back to baseline. So it's not coming to market. Pfizer product, not coming to market. These are already out there. And we are really anticipating in the first quarter of 2017, we're going to know the results of a study of 22,000 high-risk people. Question, will the payers still kick and scream and not pay for it? That's a good question, because it's all about the payers. Can you imagine if these were generic drugs? If these were $4 drugs? Who's not going to take a sub-Q injection once a month? Please, I think we'd be lining up because they look safe, but let's stay tuned. We've got to have more data. So if you just look at why we do what we do, we get the best bang for our buck. In this with alirocumab, when you give it 150 every 2 weeks, you start at 75 with this drug and you go to 150 every 2 weeks. That's how it's delivered. The other drug can be given once a month. We have no floor. We do not know if there's any risk in lowering LDL. In the studies that have looked at alirocumab and evolocumab, LDL has been reduced to 0, and there has been no problem over 2-year follow-up. I don't know. I don't know what the floor is. But in blood pressure, we know there's harm in lowering blood pressure too much because we need blood pressure. We don't know that with LDL cholesterol. Interesting.
No cognitive deficits with lowering it too low?
So far not. Stay tuned. Cognition is very important. How do people think when their LDL is lowered that much? So far not. But we're going to have these outcomes and these side effects. We're going to know it. So in our particular patient, yes, we want more LDL reduction. With the ezetimibe, it only got down to 125, and we still thought the patient was at risk. By the way, tendinous xanthoma, Achilles xanthoma, will melt away when you get the LDL reduced significantly. Melt away. Yep. So these drugs are effective on or off statins, on or off ezetimibe, with or without familial heterozygote, or clinical ASCVD. And it doesn't matter the background of therapy. On a statin or a statin and ezetimibe, or by themselves, they lower LDL exactly the same amount, 55 to 60%. But because statins are so beneficial, we want to use statins in these patients. Okay. There are little differences in the drugs. I do think you should check the LDL 4 to 8 weeks after you use either of the drugs. I think it's important to know how they're responding. I feel that way about statins or statins with ezetimibe. Little differences in the shelf life. Evolocumab is also approved in homozygote hypercholesterolemia. So our patient, all the kids were screened. The brothers and sisters should be screened for familial hypercholesterolemia. Her kids should be screened for familial hypercholesterolemia. Her LDL is now down to 58 on a statin ezetimibe, atorva 80, 10 of ezetimibe, and a PCSK9 inhibitor. This just summarizes all of this in a 2014 paper. And I'll open it up for questions, and then we'll go to Dr. Rosen. So, questions about this area? Yes.
So I see in the bottom you said awaiting results for, outcomes like
Yes.
lower cholesterol. Are there any studies yet showing decreased incidence
Of events?
Yeah.
There is, in the safety studies that were published in the New England Journal in 2015 on both alirocumab and evolocumab, there was an observation in non-double-blind randomized trials that event rates are reduced, significantly reduced, with both,
Statins or compared to nothing?
compared to whatever the background is. Statin intolerant, statin tolerant. However, these are not double-blind randomized trials, and there can be confounding. These are open-labeled observation. But these trials I told you about, these are huge trials that are double-blind and randomized and conducted properly. And we're going to know the results in 3 months, March 2017.
Secondary or primary?
They are both secondary and primary. And that is an interesting question because, gosh forbid, they should be beneficial in primary. These insurance companies are going to be hemming and hawing and fighting you all the way. I just don't see it being put in the water. High risk, maybe. $14,000 a year.
What if you have the insurance companies are going by LDL, and if you have a high triglyceride, your LDL is going to be falsely lower. And
Well, no. You can get a direct LDL now from almost all labs. And it is about the LDL.